Hi, and welcome to the Restorative Wellness Clinicians Corner, video series exclusively for functional health professionals, where we interview the top experts in the latest research, products, tools, and best practices for getting your clients exceptional results. Hello, everybody. I am recording this on Marathon Monday, a very exciting day over here in Boston. I hope you're having a fantastic day wherever you are listening to this. Today, we have a very interesting conversation with you. I interviewed Dr. Robert Whitfield, who is a plastic surgeon who accidentally ended up specializing in breast implant illness, which is something that I don't think gets discussed enough. We talked about the ins and outs of this. What are some things you want to be looking for with your clients? How do you support them, and when do you support them with their detox pathways? And what are some things that we can be doing as functional practitioners in terms of conversations with clients, when to consider this, how to support them through this journey in all the ways that we do, when to refer out, all that good stuff. So it's a great podcast. I hope you enjoy it. Welcome, everybody, to today's episode of the RWS Clinicians Corner. We're super excited to have you here today and have our very special guest, Dr. Rob Whitfield, who is going to be talking to us about something that we haven't talked really at all about, but is so topical. In fact, just last week, I had two different people on separate occasions ask me, what would you do if you suspect your client is actually dealing with issues due to breast implant illness? So this is really topical. We're going to get into it here today. Even I just noticed in the chat, Heather shared for our live audience, she shared that she has 2 ruptured breast implants, and a week from tomorrow is having explant surgery. So super, super topical. We've got lots of great questions. I want to introduce you to our fantastic guest, Dr. Robert Whitfield. MD is a world-renowned holistic plastic surgeon certified by the American Board of Plastic Surgery. He's an author and the leading expert in breast implant illness, known for his pioneering surgical techniques and groundbreaking no-cut facelift, which we could probably have a whole other conversation about. With a deep specialization in oncology and microsurgery, Dr. Whitfield is at the forefront of advanced breast explant procedures, delivering exceptional patient outcomes worldwide. His practice in Austin, Texas is built on the Strategic Holistic Accelerated Recovery Program, or SHARP, which we're going to be talking about today. It's an innovative protocol that optimizes recovery and promotes comprehensive healing. Dr. Whitfield's work has earned him consistent recognition on the Texas Super Doctors list as one of the best doctors in America. He's host of the popular podcast Breast Explant Surgery and Recovery, where he shares patient stories, explores cutting-edge treatments, and discusses the latest advancements in plastic surgery. Dr. Whitfield received his medical degree from the University of Las Vegas School of Medicine. He then completed 6 years of surgical training and a plastic surgery residency at Indiana University Medical Center. He then returned to Nevada for microsurgery fellowship before settling down to practice and teach at the Medical College of Wisconsin for 7 years. In 2012, Dr. Whitfield came to Austin and became renowned for his breast surgery expertise. In 2019, he was chosen to speak at the FDA hearings on breast implants and their safety. And in 2024, just last year, he published his first book, SHARP, the Strategic Holistic Accelerated Recovery Program, to share his protocol and expertise in holistic surgical preparation and recovery. And the same year, he published his first scientific paper on microbial communities and associated biofilm in breast augmentation failure. So this man knows what he's talking about. Thank you so much for joining us, Dr. Whitfield.
I may have to shorten that for you in the future. That is all right.
Well, you know what? I actually tried to shorten it. I'll be totally honest. I tried to condense and pull things, but everything was so relevant to what you're doing. And I want everyone to know how much expertise you come from.
Oh, I apologize for that.
No, don't apologize. Never to apologize for that. What I would love to add to this is understanding kind of your personal story in terms of what got you from where you started to specializing very specifically with breast implant illness. It's not something that a lot of people are talking about, not something that enough people are talking about.
Sure. I mean, first of all, thanks for having me, and I appreciate being able to speak to the community you have. My background and training really is in oncology and reconstruction for cancer defects. So in that capacity, there's things that we can do for head and neck cancer, for sarcomas, and for breast cancer. Breast cancer is the most prevalent cancer that we would face for reconstruction. So just by default, you would see more patients. And so for everybody listening, our country is expansive. I'm in Texas. The entire country of Spain can fit into Texas. And so in our United States, when we're kind of faced with a patient who has a breast cancer diagnosis, as soon as you get outside of we'll say major cities, we'll say above maybe 1.5 million, your options for reconstruction will diminish based on the community setting, the hospital setting you're in. So although you could have a mastectomy and a reconstruction, or a lumpectomy and radiation therapy, which have been the standards for a long period of time now, in order to do microsurgical reconstruction, which is what I did, you would need a different setting. You would need the nursing staff in the operating room. You would need the instrumentation in the operating room, including a very expensive microscope in the operating room. And typically the support staff on the wards afterwards, whether it's in the intensive care unit setting or on the ward itself, where the nursing staff really took care of the patients and would monitor things for you afterwards. So when I would do a reconstruction with your own tissue, think of the tummy tissue that's discarded in a tummy tuck. We would save that and preserve the blood vessels to it, and then hook those up underneath the breastbone, and that would create the breast mound. And then later on, we would do fat grafting to help round out or complete the result, whether it's size, shape, volume. And I did that for a number of years, and because the implant-based reconstructions are by far the most common, I would get the failures of those reconstructions sent to me. And rather than repeat plan A, which would be to do another reconstruction using an implant, I would just, if I could, offer the patient their own autologous reconstruction. So use your own tissue to perform the reconstruction I just said. So I was actually probably taking care of this problem before I knew what the problem was.
That's fascinating.
And then fast forward 2016, I had a implant-based reconstruction patient relocate to Austin and desire to go flat. And I saw them in consultation. I did that procedure for them. And for everybody listening, I send everything off just as I always did when I was trained. I send them off, one, to make sure there's no recurrent cancer, so that goes to pathology. And then two, I send, at that point, regular cultures, which were more like swabs. And those would go for culture and sensitivity to make sure there wasn't an underlying implant infection. Fast forward a week after her surgery, her path was negative. She had no evidence of recurrent disease, which is always first and foremost. And then she had an E. coli infection. So that was pretty startling for me because she had nothing on her labs, nothing on her diagnostic studies. And, the only symptom she complained of was fatigue. And for patients who've had chemotherapy, bone marrow suppression, that was a pretty common complaint. So that was something that, I didn't really take into consideration then. But now I see all the time in the cosmetic world where I have patients show up with inordinate amount of fatigue, and there's some genetic predisposition we can talk about, and there's some toxicity issues we can talk about contributing to that. But that's how we got introduced to it. And then doing the, capsulectomy, which is it's become controversial, which is just kind of silly. It's portrayed to patients as it's not safe, it's difficult and dangerous, which is somewhat embarrassing for me to hear as someone who's operated for almost 30 years now. That's not a difficult to do surgery. It's not dangerous to do. And you shouldn't portray that to the patient. And I always tell patients, and everybody listening should understand this too, if they have a patient go to a provider like me who says that, they should send them somewhere else, or that patient should just know to go get another opinion, because that's not, that just increases their anxiety. It's not a thoughtful thing to do or say for a patient.
And that specific procedure that they're saying is risky. Can you say the name of that again, just so everyone, because it would.
Yeah. So in the breast implant illness community, it started off, people kept asking for an en bloc resection, which is a pathology term used to describe tumor resections. But really, doing a total intact or a complete capsulectomy is it's basically getting all the material out. And I try to take it out like I describe it as an undisturbed Easter egg. So
Right.
you're not really cracking the shell
Right.
and damaging it, because if it has a lymphoma in it, which can happen, you don't want to spread that.
Of course.
And if it's infected, you obviously don't want to spread that around the pocket as well.
Okay. Okay. Got it. Excellent. Thank you. So can you explain, just so we are an audience of clinicians, but just this idea of breast implant illness? I know we all
Sure.
sort of have this vague sense of what it is, but can you define it really specifically and share with us some of the hallmark symptoms of it, if it has hallmark symptoms?
Sure. I consider it a chronic inflammatory process of which the breast implant's playing a role. So whether you think of the inventory of symptoms from head to toe, I have had people show up with brain fog, headache, light and sound sensitivity, dry eyes, dry mouth, difficulty swallowing, chest pain, shortness of breath, musculoskeletal pain, joint pains, heart palpitations, gut issues, cramping, bloating, swelling, diarrhea, intractable UTIs, intractable bacterial vaginosis, candida overgrowth, proctitis, athlete's foot, rashes. If you can think of something,
Okay.
they've rolled into my office with it. And
Right.
then, the way I think about it now is we all have this genetic code, right? We inherit it from our parents. And I always joke, you can't pick your parents and you can't outrun a bad diet. So if you don't detox well to begin with, and say, for instance, you're estrogen toxic and you've been exposed to mold or Lyme, or you have environmental toxin load that's too high, I mean, you're just a setup for this problem, just as you are for many other chronic inflammatory type situations. And just adding a medical device, if you think of it, that's not a good mix.
No, not at all. So it's kind of that client who you've gone through, they're not improving despite doing the things that you're thinking of, and they have breast implants that haven't been looked at. Would that be a good time as a clinician to start thinking about that?
Yeah, and then we published the paper last year to look at a series of explant specimens. So if you just take out the scar tissue, which is around the implant, we send it off for PCR testing. And 29% of the 600 we tested had a bacterial contaminant. Number one contaminant was Cutibacterium acnes, which used to be called proprion bacteria. And number two was Staph epidermidis. And also in 2024, at the actually Indiana University Medical Center where I trained, but well after I was gone, a scientist who studies biofilm found that patients who had bacterial contaminant on explant had higher levels of oxylipin tenhome in their blood. So oxylipin tenhome comes from oleic acid in the breast tissue being oxidized. So downstream, basically you'll get macrophage polarization, long drawn out story to basically tell you all the symptoms I listed in that inventory can be associated with that elevated biomarker. To date, you can't commercially order that, but I introduced the scientist to a lab company to hopefully get that made commercially available.
Okay, that was going to be my next question, is how is this diagnosed, and are there specific markers, or is it something that you're doing, like a biopsy? Like how is this diagnosed?
Yeah, so, unfortunately, diagnosis of exclusion, but it's pretty biased in my sample because patients, first of all, for everybody listening, I don't tell anybody they need an explant. That's a very difficult decision that nobody wants to have a discussion with me about. And nobody wants to travel and spend a week in Austin, which is basically the game plan. When they do that, in 29%, I've let them know this is what we find. But then, okay, Rob, what's going on in the other 71%? So that's a combination of genetics and tox burden, gut health, metabolomics, hormone imbalance, as everybody listening on this call can probably attest to, having patients who have those problems. And then, I think a lot of people want those answers because they've been siloed into these different areas in their journey, we'll call it, to learn why they're experiencing what they're experiencing. So basically, when people tell me, what's going on, I'm not really listening to make a diagnosis of breast implant illness. I'm actually trying to listen to how they detox. And they just sit there and tell you, if you just listen to them, how poorly they methylate, or, they'll just 2 hours ago, lady was trying to kind of barter with me about doing a fat transfer, which is a common kind of situation because people did this to get volume because they didn't have enough volume. And fat transfers are very good and should work in every single situation, barring like a hormonal imbalance or a toxicity issue. So this patient, like when you listen to them, and everybody probably on the call or in the audience, I'm sorry. If you've ever had a patient with mold that's have a difficult time, they have a lot of trouble following conversations, and they have brain fog and all these like light sensitivity, sound sensitivity, all these little like tells, but they still want me to do their fat transfer. And I tell them kind of universally, I'm like, well, here's the deal. We're going to look at your genetics and we'll look at your toxicity burden. And I can almost guarantee that you have a bunch of mycotoxins in your system. And there's really no way for me to help optimize you until those things, to a lesser degree, are getting detoxified from your system. And I don't know how to navigate that, any easier than help them along in the process, because that amount of tox burden really, it's difficult for them, and you can see them struggle with it, and they try to explain, how they do, get through a day. And it's pretty bad.
Yeah. Yeah.
So
when you have a client in that kind of situation, and and I would assume that this would apply whether kind of in any of these contexts, whether you're talking about the fat transfer or you're talking about even an explant, if you know that they're not detoxifying properly, are you supporting them then before any kind of surgical procedure as well as after? Is there sort of an order of operations that you're making sure they go through in order to be prepared for that surgical piece, whether it's the fat transfer, whether it's an explant, whether another reconstruction?
Yeah. So many times, all I do now is explants. The fat transfers are either simultaneous or delayed, so in the future. But to engage with us, basically we start everybody on sharp, and that's to do all the tests we described. And then we've curated a series of supplements that are basically liposomal to support immunity. So vitamin D3, K2, glutathione, some vitamin C, some methylated B complex, some glycine, some things just to support them. And then obviously we recommend that they add some trace minerals back in. But I have a bunch of people with a lot of dietary problems. They struggle to absorb. So it's half the battle is trying to get them tuned up enough to have surgery. And then we have a detox program. Currently, we leverage CellCore for detox in those patients. And I have a whole team that runs that. And that starts depending on when they're going to have surgery. So if people are 6 months out, they'll probably do a little bit of detox, but then the majority of the people will do most of that afterwards.
The Clinicians Corner podcast is sponsored by Restorative Wellness Solutions, the premier clinical training program for health practitioners who want to learn how to finally get to the root source of their clients' health concerns and help them reverse complex health challenges and chronic illness. You can't afford to keep guessing. Your clients can't afford it either. Today's clients are sicker than ever before. Their health histories are more complex than ever before. And you simply can't deliver the results they crave or build the practice you desire without the right clinical skills. Enter Restorative Wellness Solutions' foundational course, Mastering the Art and Science of Gastrointestinal Healing, our clinically proven, systematic approach to restoring balance within the body that has helped over 1,000 practitioners transform their clients' lives, grow their business, and change the way health is delivered. In less than 12 weeks, you'll develop the clinical skills and confidence you need to help your clients feel better, faster. Learn how to work with advanced lab testing to identify food sensitivities and imbalances within the gut. Craft custom targeted protocols that truly resolve your clients' gut issues, and work safely and effectively with supplements to deliver consistently life-changing results. Visit masterguthealing.com to apply today. Okay. So I'm just thinking it from the context of, our clinicians, right? They're working with clients. They know somebody has breast implants. They know that they're not getting places. We're doing a lot of the same functional tests. And I do want to dig into the SHARP process and what very specific tests you are looking at. But they're looking, they're going to be looking at diet. They're going to be looking at gut. They're going to be looking at food sensitivities. They're going to be doing extensive bloods, sometimes also hormones. Sometimes they're going to be digging into toxins, right? Like they're depending on the focus in their practice, depending on, where they are in their training, they're going to be digging in. When is the moment when they say, okay, we need another set of eyes here? And as you said, I think you said a really important comment of like, you're not the one having the conversation with them about whether they do an explant or not. It's a very sensitive conversation, a very personal decision. How would you advise clinicians who will be seeing this and are seeing this in their practice to navigate that? Should they just continue with the functional work? Should they recommend them to speak to somebody? And then who is that person that they speak to about this, and to kind of support them to determine if this is something that is a piece of their puzzle?
Yeah, I'll give you what I wish, and then I'll give you reality. So what I wish is that everybody could have that conversation with those patients that have devices in place, because if they're not in alignment with them and their body anymore, then they really need to be kind of guided along getting an explant. And sometimes that's going to be the people on these, calls that I do and these podcasts I do that help recommend that, because it's not easy. You're not going to go back to your plastic surgeon who had those placed for you or helped you get them placed and typically get that answer, because that's almost like a failure to launch, for them. And if you're asking me specifically, when is the time? So I've had people as early as, 6 months, maybe less. That means they got typically infected or something happened at the time or near the time of implant placement. And then I have people, 10 years, 15 years, 20 years later, and multiple children, moving, different things in life, and it all kind of catches up to them. And it seems like it hits them with a ton of bricks at one time, and then everything just, women invariably tolerate a lot more, and then when the wheels fall off the bus in a bad way.
Yeah.
That's basically what I see. And they kind of do everything and then can't do anymore.
Yeah.
I would prefer to get them a little bit earlier in the process. That would be nice.
So who do we recommend? I mean, I know, we're going to share your information at the end, and people can book discovery calls with you, and you are one person. So, when you fill up, after, I'm sure you already have filled up, where do they, is it appropriate? Do you think it's appropriate for a functional practitioner to be having this conversation and kind of gently, even if it's just educational, right?
Yeah, I think you have to. We've tried to add surgeons, so we have more surgeons now on staff.
Right.
And, the scaling of it is the problem, right? I can't obviously take care of and talk to everybody. When I listen to someone, just like you're listening to me talk, it makes probably a little bit more sense, but that's the only consult I do now, basically. So I hear it all the time. If you're just hearing this for the first time, either on this show, or you haven't quite wrapped your mind around what is going on, I think I would recommend that everybody think more about how someone detoxifies. So if they have trouble with skin health, if they have trouble shaking a viral illness or a cold, and everybody kind of knows what I'm talking about, they stay inflamed longer, and that's typically a problem with their methylation pathway. If they have difficulty with strong odors, or if fragrances really bother them, or they have problems with mildew or mold, and they tell you that, they typically will have some problems in their glutathione utilization. Then finally, if people complain of extreme fatigue, I've found them to be more likely to have a SOD2, problem, so superoxide dismutase problem. So if you feel like those things are lining up when you're talking to somebody, then that's basically my avatar. All you need to do is sprinkle in estrogen toxicity, and that is the worst possible combination of a patient I see because they don't detoxify well. They typically suffer from adrenal fatigue and they have elevated estrogen levels. So now you have all the bad things happening all simultaneously. And to boot, if they have and belong to that 29% have bacterial contamination, they have this oxylipin 10 home in their system that's stirring up their immune response. So they can never get out of that cycle. And it's like, I call it being the hamster in the wheel. They can't really get off of that. They can't ever catch back up.
When you say they can't ever catch back up, do you mean they can't ever catch back up if they aren't supporting detox, or they can't catch back up unless they support detox and have the explants?
So I have a whole group that asked me that question all the time. And so do I, and one of our colleagues asked me this routinely, do you think you can solve this without an explant, Rob?
Yeah.
And so I know for sure I can lower inflammation in patients prior to explant.
Yeah.
You're asking a specific question depending on the patient and how they, detoxify plus all their exposures. So that's the issue where I can't say, yes or no. I'd love to say, oh yeah, I can manage this for everybody, but I know better than that.
Right.
Because we're all going to take care of patients who get way more exposures than they can cope with. And so building up and supporting their immunity and giving them enough in their diets. I have a big thing with people in their diets. They're all out of whack. Mm-hmm. And they get so many problems with leaky gut or just inflammation. It makes it difficult to care for them. Maybe if that part were solved or temporized, it would be easier for them. But I found a lot of people really struggle. And if your gut is completely off in this scenario, I have found explant to be more needed in that scenario versus being, put off longer.
Right.
So that's, I don't have a audit of my data specifically to tell you that, but that's a more anecdotal.
Well, trust me, our audience is very used to us saying it depends.
Yeah.
Because every individual has their own unique presentation, history, constellation of symptoms and exposures. One of the things we are always saying is you can't get well in the environment that made you sick. And yet, of course, we live in an environment that is, it's a bit of a toxic soup out there. So I think, what you're saying makes a lot of sense. It's going to depend on that full constellation of exposures. And it could be that the breast implants are the tipping point, that proverbial straw that broke the camel's back. And it could be that if we can get other pieces moving, and I think, you're never going to have to talk long for this audience to convince them on gut health and diet. That's right. Our starting point with pretty much everybody. So, so I would love to jump into the sharp process. Sure. And I'm seeing there's just so many questions in the chat. I'm seeing them come through. I haven't been following them quite yet. I'm going to dive in. I want to make sure we have a few things, but sure. I'm going to be going there shortly. But let's talk about this sharp process and how you're structuring that. What tests that you're using? What kind of pieces that you're working with here?
Yeah, it's what we've been talking about. It hinges on your genetics. So we're currently using Envision Labs for genetic testing because they include drug metabolism testing. So if you have a patient, and we're all concerned about their immunity, we're also concerned about how they metabolize things like estrogen and their mood and sleep, all the things, we look at those. And then we're looking specifically for some drug metabolism issues, because a lot of patients in this group will be very sensitive to drugs. They may be very sensitive to using things like lidocaine. So we're pretty careful about our protocols with how much of each thing we're going to incorporate. We do incorporate things for nerve pain and nausea and inflammation pre-op, but we try to be pretty narrow in our focus in how much we're using for what period of time. So that's part of it. And then for tests, currently I like using the Vibrant Wellness Total Tox test. It gives me a pretty broad picture, but I'm open to and always exploring, testing and looking for more options. We vacillated between some different GI tests. I think starting with the GI map's kind of just an easy, low-lying fruit, that everybody's comfortable with. My detox team really likes that. And then I think I've probably tried the most food tests in the group. So we've settled kind of doing an ALCAT 250. It's pretty consistent. We've added using the metabolism Aristotle test from Theriome because it gives you more of a score of inflammation. And then we do a battery of blood work, probably like many folks do. I look more for, I'm looking at hormones, and typically people have had so much blood work by the time they get to me.
Yeah.
That's really, basic things like you can't be anemic, of course, and you can't have a really low platelet count, and your renal function has to be appropriate because anesthesia's not going to do your case. But I'm looking for people who have a lot of hormonal imbalance. So we look at, not just estradiol, but we're looking at estrogen levels and free testosterone levels. I see a lot of testosterone suppression in women, which contributes to all sorts of other problems. So I probably get out on a limb too much and say that if everybody knew that they would get no libido after having breast implants, they probably wouldn't do it. So having, testosterone suppression to me is just a greater inflammatory kind of side effect, probably.
Can you go back on that? So no libido after implants. Is that because of the testosterone suppression, because of something in the implants? Can you make that connection? I think that would be a really important one to highlight.
Oh my gosh, it's more of an association than a causation. I heard that the other day, so I got to be careful now. Yeah. So I see it pretty routinely is a very, very low free testosterone level. And typically, and maybe in your community, they've experienced this too, is where people don't react properly to bioidentical hormones because obviously hormones work. Mm-hmm. We know this because all the athletes wouldn't spend all this time avoiding testing and wasting money and possibly getting arrested and losing their legacies if they didn't work. And I routinely get people come in and say, oh, bioidenticals didn't work for me. I'm like, I don't even know what that means. Like, what does that even mean? You mean the hormone doesn't work or it didn't reach the target or you didn't have enough of it? Because that's how in my head, I'm like, right. Of course drugs, of course they work, but like, I don't understand like what is going on. So we do see that. And I want to know too, because if you give someone a surgical plan, yeah. And you put them through all this and you don't know that they have almost a non-detectable testosterone level, how are they supposed to recover? That doesn't really work. So for recovery, which everybody wants me to get them recovered in the shortest amount of time with as little swelling and bruising as possible, of course, we will augment that, if we need to, based on the findings.
Okay. With the blood work, are you looking at, because since this is so much about inflammation, are you looking at specific inflammation markers? Are you tracking that through the journey, or is it more just, are you looking at that from more of a symptomatic perspective?
Oh, we stopped because none of them work. They don't help. So SED rates and CRPs and highly sensitive CRPs don't really show up in this patient population in a consistent way. And we looked, oh my gosh, we looked at so many things. Interleukin levels and LPA. Oh gosh, what else have we looked at? I mean, I've been on this, chasing this for ages now. We did have a urinary marker that was a thromboxane A2 metabolite test, but the company went out of business. It seemingly worked, but it was super sensitive to adjustments in dietary intake of turmeric, curcumin, NSAIDs. Anything would change it, throw it off. So you had to get them before they knew anything.
Right.
Test them. And I fortunately had a few completely naive people do that test, run the program. They actually were teachers, so they couldn't come for several months because of the school year. And by the time they got to us, they had dropped their inflammation significantly. So we had our own little
Right.
case controlled, cohort, if you will. So that was a specific test, but it wasn't going to be sensitive enough in the long run.
Well, that's actually really helpful to know for, because our practitioners are going to be, we look at blood work all the time. And if that's not something that you're going to see.
It's not reliable at all.
Yeah,
If someone tells you they don't feel good and have breast implants and their CRP is normal and they're highly sensitive or highly specific CRP is normal or their sed rate's normal, it means nothing.
Yeah. Right. Okay. That's really helpful. I want to ask something about the gut testing. I forgot to ask earlier, but I was thinking about it when we were talking about the GI map. Do you ever see evidence of, somebody who has an overgrowth and either opportunistic or even, overt pathogens in the gut? Do you ever see sort of translocation and see evidence of that when you do the explants?
Yeah, the top two are always Cutibacterium acnes and Staph epi. Okay. So Cutibacterium acnes is in highest concentrations on the face, neck, chest, and shoulders. Yeah. So that's more of a skin issue.
Right.
And then Staph epi, similarly, the gut, I've had and found everything, but it's not to the level of the correlation between a GI map and a explant PCR. It
doesn't quite. Okay.
No, and it's not mold. Oh, for everybody listening, please, it's not mold. So I did this study, and it was 5 cases out of 1,000 that had fungi. So mold is not a thing, despite what TMZ and all the internet says.
Okay, that's also really helpful to know. Let me just check in on our chat here because I'm seeing lots of activity, and I want to make sure we get these questions answered.
Sure. Take some questions.
Some commiseration. Kristen saying she's had 3 surgeons telling me the capsulectomy is dangerous and they may not be able to fully remove it. So Kristen will share information with Dr. Whitfield. Maybe you make a consult there. Great question from Anne here. Can you explain why the body creates the capsule?
Yeah, the capsule just is formed around anything that's foreign. So if you got a splinter in your hand, you would create a capsule around a splinter if you didn't get it removed. So it just walls it off. It's just a formation of collagen, if you want to think of it like that.
Right. Are we thinking, is it, would you say it's the same as biofilm?
No. Biofilm is from a colony formation of bacteria. Biofilm is like plaque.
Right. Right. But of course, the two are very close, so you must have biofilm buildup on that. Okay. How often do patients reject the fat transfer?
So you actually can't reject the fat transfer because it's autologous. It's your own genetic material. So you're then asking, how often would it get infected? So that should be less than 1%. And then is there a problem with necrosis or oil cyst formation? Now, those will vary based on who's doing them. That's really, really low in our practice, but I've done several thousand. So you don't reject a fat transfer. People will question its longevity. So I will give you my take on this. So if you have a patient whose tox burden is low, so you get a Vibrant Wellness and everything is below the 75th percentile, so that means everything's to the left.
Yeah.
It's going to work virtually every single time, barring a couple exceptions. If someone has no hormones, you can't have somebody who is, postmenopausal without any estrogen or testosterone being produced at levels to maintain, homeostasis. So I always say the same things. The closer you are to 20, everything works great. The closer you are to 80, gets much, much more challenging, and you have to have, not just hormonal balance, but obviously dietary balance. And then just for everybody listening, patients are going to be using all of these GLP-1 agonists, and there's a whole new series coming that target just fat, not muscle. So just today, I had a patient come in who we did a fat transfer on, and she wanted more fat, but she was taking a GLP-1 agonist. And I was like, well, we can't do a fat transfer. If you want to maintain a fat transfer, you shouldn't actually do this, peptide therapy. Like
Right.
it doesn't align with what you're trying to accomplish. So people are going to burn their own fat because those drugs work extremely well.
Extremely well. Yeah. Now that actually opens up a question, and this might be just a total ignorance question. This is just so out of my normal realm. But if you have somebody who does a fat transfer and they do lose a tremendous amount of weight, GLP-1s aside, but they do lose that, that's going to affect. I mean, obviously
Yeah.
that's part of the body's. Okay, that's really.
Yeah, so I always will guide people on like, I don't want anybody eating a garbage diet. I don't advocate for that at all. So healthy fats have to be part of it. I always have people on a higher protein diet, like a gram per pound of body weight in protein. You know, I don't, I don't, I don't know how to guide people on, who really want this volume restoration, but it doesn't align with like the things they do. Like they want to do hit or they want to do high cardio workouts. Like those things don't align. Like if you're a woman who's trying to avoid osteopenia and osteoporosis, you should be lifting weights, not doing hit and not doing a bunch of cardio anyway. Walking's a great exercise. I know it doesn't sound exciting, but walking and lifting weights, especially, weights are going to help you. And you're not going to get bulky, and eating higher protein diets are not going to make you bulky. I mean, all this stuff sounds farcical when I hear it recited to me, but if you want a fat transfer, you have to have fat.
Right.
That's
And you have to
main
maintain
thing.
it. Yeah, absolutely. So just to make sure, are there any other strategies that can be implemented to maximize fat retention and long-term aesthetic outcomes?
Yeah, I think keeping your tox burden is most important in check, because stem cell activation or think of, I have so many people come in this really hyped up, stressed out state, and they have a lot of toxicity. They don't sleep well. They don't have a good diet. They may be ingesting, liquids that have phthalates because of what they're drinking out of, or what they're utilizing. They may have arsenic in their groundwater. Like if you do a tox test, you'll find out a lot about how people either grew up or where they currently live or work, because they have so much environmental pressure on them. And I always tell everybody, I'm not Harry Potter. There's no magic involved here. So, your body has to heal whatever I do. I'm not the rate limiting step. I've done thousands of fat transfers and thousands of explants. I know exactly the steps to follow and how to help guide you through the process. But the thing that keeps changing in front of me is always the canvas. So I have to make sure that we try to get everything optimized for each person to the best of our ability.
Teresa shares that she had explant and capsulectomy surgery 2 months ago, but doesn't think the surgeon did a swab of the capsule. Is there any way to know after the fact if there was an infection, and what can she do about it?
No. I mean, if they did a complete capsulectomy and, that's basically the treatment. I do verify each of ours in every case because I don't want to answer that question.
Right. Yeah, exactly. Would you say that the presence of capsular contracture is a sign that the immune system is rejecting the implants and they should be removed?
No, I would say capsular contracture represents more of a bacterial contaminant problem. I would say that's going to be the largest factor. And then post-op, if someone had a hematoma or seroma, that would contribute to capsular contracture. But in the breast cancer world, it's always like, did they get radiated? Did they have other things going on?
Right. So I want to keep asking some more of the questions here. Is there anything that we as practitioners should avoid doing in a client? A client comes and you suspect that breast implant illness is a part of the piece of the puzzle. What I am going to say, and let me know what you think about this, but I think everyone should add to their intake, always asking about, when we ask about exposure to mold and water damaged buildings, we ask about, dental work and all this kind of stuff. I think we should be asking, about breast implants as well for all female clients. Would you agree with that? Just so you have that information, because it's easier to ask it upfront in an intake than it is to go there later on.
I think you have to, and the reason being is people forget they got them. They become very, um, should I say forget? They don't want to talk about having them. They don't want to put that down.
Right.
And, you know, here's how I ask about it. If I'm in your position and I'm hearing a conversation that sounds like what we're talking about.
Right.
If I don't see it on their intake form, I'm going to say, hey, have you had any surgeries of the breast or body? You know, have you had any cosmetic surgeries or anything of that nature? And they may forget. Commonly people tell you to me, they forget they had liposuction.
Mm.
So that's it's not even considered surgery because it's done under local a lot.
Right.
So asking about that, but then for breast surgeries, you know, you can say, hey, I just want to make sure you haven't had a lumpectomy, any other breast surgeries at all.
Right.
Because then everybody will be like, oh, no, I haven't had, but I had an augmentation. And then if you know, it gets, you know, that kind of, you know, conversation happens, then you have to say, okay, have you had any surveillance studies? Have you had an ultrasound to look at the integrity of the implant? Have you had a mammogram? Now, people are very off getting mammograms if they have implants and it causes pain. So now you have somebody who's not been surveillanced properly for cancer, depending on their age. So now you have a whole laundry list of things to potentially go through, sort out. And our friend Jen has QT imaging available that's non-invasive. High definition ultrasound is still, if somebody doesn't want to have a mammogram, say, hey, do an ultrasound. MRI devoted MRI for breast is an option. There are a lot of ways to get this evaluated, and I would just not take a lot of excuses.
So if a client does have any kind of implants, making that assessment, you know, getting them evaluated, what would be the frequency? Yearly, twice, every other year, or what? Does it depend on their age? Does it depend on why they got them? Like if it was for, I mean, you know, when somebody has had breast cancer, of course, they're going to be much more routinely checked.
Right.
But a lot of times this is for cosmetics, so they're not thinking along those lines.
Yeah, I mean, typically the follow-up was annual, but plus 10 years out, you should have some diagnostic evaluation of it.
Mm-hmm.
And then based on that, at least an exam. You know, the thing is always cost, right? So like high definition ultrasound is a one-time investment for our practice. So typically, you know, more and more plastic surgeons have them, but that's the non-invasive way to look at the shell, not the breast. If you're looking at the breast, then that's really a, you know, more of a insurance world phenomenon. You're going to get a breast ultrasound.
If somebody has a client who has had or is already, you know, scheduled for an explant, but they're doing it with sort of, I'll just call them a normal doctor, for lack of a better term, somebody who's not thinking, if you know, foundationally and functionally the way that we're all thinking, are there any, you know, is there any harm in supporting? And I can't see any reasons not to support the individual and all of the things that we're talking about here before, during, and after that process. Is there, are there any other things that they should be talking to their doctor about? I think we're talking, you know, swabbing the capsule seems like a really good piece of the puzzle there. And if we get something back, is that something that then needs to be treated, or, you know, what are you doing with that information?
Yeah, there's two things. So we stopped doing swabs and do PCR, which is just, PCR requires a thumbnail, you know, biopsy specimen be sent. And we use the company Microgen DX out of Lubbock, Texas. So they would have to have an account. Otherwise, they would have to revert to doing a swab. And that would be the send it off and hope that something grows. Now, understand that anything that's below 10 to the 6 colony-forming units on a microscope will not be considered an infection. And that's very much going to miss most of what we're talking about.
Oh, wow. Okay. So a swab is actually not that helpful. Like it's a very significant sort of second-class citizen to the PCR.
Correct.
Yeah.
So the reason we switched in 2019 to PCR was because I was not comfortable with what we were getting back, you know, on swabs.
Right.
And then we run the Sharp program independent of my practice now. So we opened it up so groups can actually take advantage of that, because you're not going to find people wanting to do this from a surgical perspective because they just don't have the bandwidth. And that's fair. I don't want anybody doing things they're not comfortable with, whether it's surgical or, after the fact with any kind of medical or detox therapy. I would say for the group, do not try to aggressively detox patients who have symptoms with breast implants in place, because it is not successful and you can make people have a lot of Herxenheimer type reaction.
Okay, yeah, speak more, talk more about that. This is what I want to get into, is what are the things we need to be really careful of with these clients?
Yeah, so my detox lead, Chelsea, she tried to detox herself with Cellcore for multiple years, and she would just make herself ill. So those things, from our perspective, don't work well. So if we're doing anything, people will just do like a phase 1 type detox with Cellcore and not really go beyond that until we've done their surgery.
So you're waiting post-surgery to do that deeper
to
work.
do the majority,
To do the majority of it. Okay, so that's really good to know. So if
and then we do hold sauna. So I have this thing with sauna. So if you're doing sauna and you're feeling fine, that's okay. But if you have a sauna and you're doing it and you just don't feel well afterwards, and you have implants in place, if your clients have implants in place and they're doing this and they're telling you don't feel well, that's not a good sign.
Right.
So you would just have them say, hey, all right, let's just pause this and take a moment and try to look more deeply at this and see if this is really a root cause that's contributing to this. Now, when we take and engage with a patient, I'll tell them to stop IR sauna, dry sauna, all of it, because heat is not, in this situation, a great tool. And then afterwards, at about 90 days, we'll have them resume, but under supervision. Typically we'll have them use a binder and things, so it's not as likely to cause a Herxenheimer type reaction. And you just have to, sometimes protect the folks from themselves, because they're trying to feel better, and then these things are not helping.
Now, is this universal? Like, somebody has breast implants, they shouldn't sauna? Or is this just people who have breast implants, when they sauna, they feel worse, and or they're symptomatic and you're suspecting that this is a piece of their puzzle?
Yeah, this is the one I've taken the most heat for on the internet, so no pun intended. So basically, if you don't feel well after sauna, don't sauna, and then discuss it.
It sounds very logical.
Yeah. And then the barrel is different. Now, barrel gets up to 200, and I don't know how to guide people on that, because I don't know when the shell is degrading. You're not supposed to be able to degrade a shell, but I have a patient, Lauren Bostic, and she had the most heavy metals I've ever seen in a patient's tox test, and she would do a barrel sauna up to 212 multiple times a week.
Right. That's a lot. That's a lot. We think we don't want to heat plastics, right? Or any of these like synthetics. That makes very intuitive sense. And it also, I think just generally speaking, what you're saying doesn't sound crazy to me. Anyone, if you're detoxing, no matter what, whether that's sauna or otherwise, and things start to get significantly worse, I think there sometimes can be that mentality of like, we must push through, and there's light on the other side. And often it's the body going like, whoa, too much, too soon, slow down. And so, I think it's very, very important to know that if breast implants are a piece of the puzzle and you have that client who you're supporting with detox. And I would imagine this is, because we see a lot of our practitioners are working with people who have very severe, mold toxicity and some of these things. And it can feel like you're just going so incredibly slowly. This is a really important conversation to be having, to make sure that this is another piece, this isn't something that is going to slow down even more, and that you actually want to put the brakes on until this has been handled. This is helpful. Am I understanding when you say that you have the Sharp section of your practice is totally separate? So is that something that, say, another plastic surgeon could hire people from that to support their patient population. So there's ways that other practices, without having to learn everything that you know, or at least maybe they understand the framework, but there's people who can actually support other practices in this methodology. Am I understanding you correctly?
Yeah, we're onboarding our first plastic surgeon,
Awesome.
and then that will come online. That will be the first that we've gone outside of our purview. And then on my detox team, we've expanded that team to include group.
Okay, excellent. Now, is there, if somebody is considering doing the explant and they don't do all this other stuff that we're talking about, are there actual risks to that? Or is it simply well, you might not get full healing?
Yeah, I believe like if you follow the concept, 29% of the patients will have this bacterial contaminant. And then if we remove that, we'll say that removes the underlying, cause, if you want to think of it like that.
Right.
If we're using the oxylipin tinhome as the cause and effect of the symptoms. Now, that leaves the other 71%.
Right.
So in that setting, I don't know who is going to get better. I don't know what time frame they're going to get better. Our goal is to not have outliers. We don't want people who don't recover for, 24 months versus somebody who's recovering, in a very, matter of weeks type time frame. We want to move that so everybody's more aligned and recovering in a very, not just a complete way, but a more predictable way. So, our team can work with them, and you have to meet people where they are. Obviously, they're all going to detox at different rates, and people are going to start at different positions. So if you look at me like 5 years ago, I didn't have all of this aligned. Right. And then post-pandemic, we couldn't get people to see patients, and we had to just start doing everything on our own. And now it's become very apparent to actually help people in a more well-rounded, comprehensive approach is better for them in terms of recovery.
A couple of last questions here from the audience. We have Candy's asking, would thermograms be helpful for detection of inflammation?
I've had thermography and I stopped using it because, to be honest, I haven't found it to be as helpful as I had hoped. And I was more worried about people getting things overread, to be honest. I'm the number one cause of inflammation on this call. And every time I operate, I create more of it. And then I'm working really hard to get it to calm down. But there are lots of things that light up all over the body, lymph node chains and everything. And it bothers patients quite a bit. And they always want to know, like, what's the next thing? Why is that happening? And if it's not predictive for us, I don't see the value add.
Right. That makes sense. Well, this has been a fantastic conversation. So if folks want to get in touch with you, we have the link for your discovery call here.
Oh, right.
Is this something that they are able to freely share with their clients? Of
course. Yeah. Okay. My team will answer, the upfront questions and help, get everybody kind of sorted out. We've created and curated a bunch of assets for people. So if they want to, read the book, or if they want to listen to shows I've done, or go on YouTube, everything's there really to learn more about it. We're not, behind a paywall or anything like that. Everything's out there, so you can learn from it. I've been on a bunch of shows as well.
Wonderful. So drrobertwhitfield.com, best place to send people? Any other places we want to send them right now, or?
So I think if you go to the site and drop in, you can kind of navigate however you want within the site, depending on how you like to acquire your information.
Excellent. Wonderful. Thank you. And I apologize. I see my thing wasn't loading, and I'm just seeing a couple of last questions. Do you have time for a couple of last questions? I just want to make sure. Folks have had lots of great ones. Mary's asking, what if someone is using red light therapy? Is that
totally fine?
Totally fine. Great. Beyond breast implant illness, could a history of liposuction and multiple facelifts contribute to impaired detoxification and healing capacity in a patient despite targeted interventions? Are there known physiological changes or disruptions in lymphatic function, circulation, or metabolic processes that could result?
Well, anytime you have liposuction, you're going to disrupt lymphatic circulation. So that's from scarring. And we have 3 Flowpresso devices from New Zealand in my office. So everybody after surgery comes here the day after and they start doing hyperbaric oxygen therapy, lymphatic massage, and we have red light, and Nano-V, and I can't remember all the other things. But anybody who's had multiple procedures always has scarring, and that limits lymphatic drainage. So I would try to, in those patients, if you can increase their absorption and get their protein content higher overall, that will help them. If they have lymphatic drainage problems, I would use Flowpresso, and then if it's a specific area, get a very talented therapist to help on the specific area, but I would have them do Flowpresso like something Monday, Wednesday, Friday. For local inflammation, they can do red light, and we have like a 6-foot tall Juve. And what was the other thing they were saying?
Metabolic processes. You talked about lymphatic function, circulation, metabolic processes.
Yeah, from metabolism issues, like if they are poor detoxers, then, I would change up their supplementation from capsules to liposomals and try to get them, D3K2, glutathione. You could also check and see if they have some micronutrient deficiencies and give them trace minerals to see if that will help them. A lot of people have copper deficiencies and manganese and selenium deficiencies.
Awesome. Great question here from Teresa. How soon after explant and fat grafting surgery is it safe to begin detox?
We give people a couple weeks before we start doing anything.
Okay.
Detox is a very, very generic term. I don't know exactly what that will mean. It's going to mean different things in different programs.
Right. So maybe going past that phase 1 that you were doing before the surgical procedure, but digging deeper, right? Supporting the body to go further.
Yeah, just don't make anybody sick right after surgery by doing things in an aggressive way.
Yeah, 100%. Yeah, always wise advice, no matter the surgery. Dr. Whitfield, thank you so much. This has been fantastic. We really, really appreciate you so much learning here. Thank you for our audience. You guys have been so engaged today. Great questions. Love it so much. Such an important topic. And we will see you all here next time. Thank you, everybody.